Hi everyone. To get the not speak too loud here, I can lower my voice. Thanks everybody for coming in. I know it's very early in the morning, but for one, I'm excited about probably the first in-person meeting and seeing many people, friends from before through this and during the meeting. So we thought this session would be good to have a cardio-oncology CME session, and specifically focusing on cancer immunotherapies. And I'm here with Doug Johnson, who I introduce to you momentarily. As some of you know, I moved recently to UCSF, although I had the pleasure of working with Dr. Johnson for 6 years or so when I was at Vanderbilt. And it's good to have an oncologist at these to do this with, because he can tell us everything that's going on in the oncology space. And so it's great to be here. Just going through some of the basic stuff, we welcome everybody for joining us, both people in person and a number of people who are here virtually. We thank PeerView, not peer review, which I used to call it, for providing this session, and Bristol Myers for providing the educational grant for the symposium. We're going to have various audience polls throughout the program, and you can submit your questions and we'll answer them during the Q&A. And that's separate, of course, from the audience polling that we'll have. There is a website that you can go where you can get all of the slides, so there's no, you can sort of not, I guess this takes away a little pressure from having to write down stuff. And so all the slides will be available to you both for your own use. I know a number of people who do cardio-oncology here. So this is the website for that, and you can get basically all of the slides for your own use. And so we had a couple of questions. This is both for people here as well as people in the who are joining us virtually about basic background things. So I guess one question is what your degree and certification is, and if you can answer that. And what would you describe yourself? Cardiologist, cardio-oncologist, medical oncologist, healthcare professional, researcher. I guess we should have had, or a non-physician researcher, pharmaceutical industry. So go ahead. And then last but not least, how many patients with cancer, and this is not just immunotherapy, any cancer, with cardiovascular disease do you see every month? And this obviously applies to the healthcare professionals. Good. So as I mentioned, the agenda today, while we can cover a lot of facets of cardio-oncology, we're going to be focusing on immunotherapies. As Doug will walk us through this, these drugs are really revolutionizing how we treat patients with cancer. And so we're going to go through some of the basic and foundational concepts, and Doug is going to walk us through that, Dr. Johnson. We're going to have a number of cases that we can walk through and discuss. And then we're going to conclude at the end. So, and I think a lot of this for people who are here is probably review, but immunotherapies have really revolutionized therapy for oncology patients. I remember probably more than 12 years ago, I was at MD Anderson, and Cesar, who's here in the audience, and this was not a topic that we ever discussed, right? And so now about close to 50% of the patients are getting immune-based therapies for treating cancer. Often these are combined with traditional cardiotoxic agents. And as a result, we're seeing completely new presentations of disease, immune-related adverse events, which Doug will walk us through. And I think there's a lot to learn for us, both in the near and long-term future, especially as these drugs are being combined. So that's sort of the gaps that we thought, at least, where this meeting would sort of cover. And so it's my great pleasure to introduce Doug Johnson. I had the pleasure of walking to Doug's office in 2016 as I had landed at Vanderbilt. And I learned very quickly he probably knows more about immunotherapy than anybody else I've ever worked with. And he treats these patients regularly as a melanoma physician. So Doug?
Well, thanks, Javed. Thanks to all of you for coming. Thanks for welcoming an outsider, an oncologist, to the group. And thanks to Javed for teaching me that the heart is more than just the organ that pumps immunotherapy to the cancer. So hopefully this will be good. So one quick audience response question to start with. And the question is, cancer immunotherapies known as immune checkpoint inhibitors are FDA approved and used in what are the following settings? And so is this early stage in metastatic melanoma only, hematologic malignancy only, many different cancer types but metastatic disease only, or many different cancer types in early and metastatic? Great, and so I think we'll come back to the post-test answer as well. So let's start off. What are immune checkpoint inhibitors? Again, as Javed said, some of this may be reviewed to some of you, but just to kind of make sure we're all on the same page. So traditionally, cancer treatments have actually targeted the cancer. Obviously, that's intuitive, but checkpoint inhibitors actually do something a little bit different. They actually specifically target molecules on T cells to activate T cells, hopefully against the cancer. Now, there's a number of ways to activate T cells. If you think about a car, there are two ways to make it go faster. You can step on the gas, which is on the left side of the screen, things that activate and turn up the T cell, or you can remove the brakes, so you can remove negative regulators of T cell function. And these all are not created equally. We actually don't have any FDA-approved agents on the left side of the screen, the T cell activators, but we do have now 3 FDA-approved, or actually 4 if you count the ligand to PD-1, approved antibodies that block these negative regulators and turn up the T cells by removing the brakes, so to speak. The LAG-3 agent is the newest one that was just FDA approved earlier this year, but we'll mostly focus on the CTLA-4 and PD-1 blockade. And so to drill down a little bit more into the mechanism here, again, don't worry, there won't be too many cellular diagrams here for those of you who hate those kind of things, but these checkpoints are not created exactly equally. So CTLA-4, for example, really functions more when T cells first encounter, when antigen-presenting cells like dendritic cells first encounter the antigen and show them to the T cells. And CTLA-4 helps the T cell more or less conceptually determine whether to go after that antigen, decide whether that antigen's foreign and needs to be attacked. On the other hand, the PD-1, PD-L1 agents really work at the level of the tumor. So these are T cells that have made it to the tumor, they're ready to eliminate the tumor, but the tumor has one last line of defense, and that's by expressing this molecule PD-L1. And PD-L1 that binds to PD-1 shuts down the T cell. So blocking that interaction hopefully activates T cells in a more specific way against the tumor, whereas CTLA-4 is a bit more non-specific. Now, these are just the names of the drugs, so again, don't worry about writing these down or anything like that. These slides will be available, so if you ever need a reference on all the MABs and MIBs that we use in oncology, these are the list of the immune checkpoint inhibitors. And you can see there's 4 classes, the PD-1 and PD-L1 molecules, which work approximately the same as far as response rates and toxicities, and then the single anti-CTLA-4, which is now mostly used in combination with PD-1 and the anti-LAG-3 molecule there. Now, of course, we have these nice mechanisms. How well do these actually work in the clinic? Well, it turns out that immune checkpoint inhibitors, even just the anti-PD-1 drugs as a single agent, are actually work quite well across a number of cancer types. And this is a list of FDA-approved indications for for single-agent anti-PD-1 or PD-L1. Depending on how you slice and dice the tumor types, it's roughly about 20 different cancer types that these are FDA approved in. And you can see some very common cancers there. You can see non-small cell lung cancer, which of course is the leading cause of cancer death for one, but certainly melanoma, renal cell carcinoma, and a whole range of other kinds of cancer. There's of course a few gaps there. We don't use it yet really for prostate cancer or many types of breast cancer or many types of colon cancer, but you can see it's made a massive difference in how we're treating a whole number of different cancers. Now, if you know oncologists, if you have any oncologists in your life, you know that if we have one drug that works and we have other drugs that work, we like to just put them together. That's our natural tendency. And so we've done that with anti-PD-1 drugs, and in fact, it turns out that they are really synergistic with a lot of other, or at least additive with a lot of other types of oncology therapies. And that's true for the more traditional therapies like chemotherapy in the bottom right. It's also true for other targeted therapies, and then also true for immunotherapy plus immunotherapy combinations, so combinations of immune checkpoint inhibitors. And again, this is just a list of FDA-approved indications for these therapies. And so as Javed said, this is important when we're thinking about cardiovascular toxicities, when you have one set of agents like BRAF and MEK inhibitors in melanoma that can cause decreased ejection fraction, and then you're also throwing on an anti-PD-1 or PD-L1 drug to that. And then we're actually moving not just in metastatic disease, this is actually moving earlier and earlier in treatment. So we've been doing this a long time now in melanoma, but it's actually moved towards lung cancer and other types of more common cancers. So if this list will only grow. This will almost certainly not fit on this slide within a few years as we start using these therapies earlier and earlier and try to prevent metastatic disease rather than treat it. And again, just one survival curve, I promise. Of course, oncologists, in addition to combining treatments, we'd like to show survival curves. And so this is just the one I'll show today. And here's this is just a remarkable curve. I'll just very quickly take you through it. This was a phase 3 study comparing ipilimumab, the anti-CTLA-4 in orange, with nivolumab, the light blue, the PD-1 drug in blue, and then the dark blue, the combination of the two. And what you can see is, I don't know if many of you remember seeing metastatic melanoma patients, 10 plus years ago. And of course, this was just an absolute death sentence. Even when I went through residency and early fellowship, there's really nothing we had for these patients. Well, this is now metastatic melanoma patients, and this is actually almost 10 years out for these patients. And you're having basically 50% having long-term survival. And so we don't, and I'll be the first to admit, we don't necessarily see this for every kind of cancer. We're not curing, huge numbers of non-small cell lung cancer patients, but we're still seeing 20-30% of patients that are treated with these drugs having very long-term survival. And as we get better and better combinations, hopefully this curve will continue to rise, and we'll be able to show you even better survival curves as the years go on. This is actually just the tip of the iceberg too. I showed you that diagram that had all these T-cell checkpoints. And of course, there's so many other different types of cancer treatments, both immunotherapy and non-immunotherapy, that these drugs are being combined with. And so it's very likely that this, again, these slides of FDA-approved indications and so forth will continue to grow, that we'll also continue to use more and more aggressive combinations as our natural tendency as oncologists to continue to combine things. So we'll likely start to see triplets, quadruplets of these regimens, which again will only heighten the risks of toxicities, hopefully as well as the long-term survival outcomes for these patients as well. And honestly, as the survival improves, managing the toxicity has, of course, become increasingly important because these patients do have that chance for long-term survival. We're not talking about somebody with, unfortunately, a median survival of 3 to 6 months anymore. We're talking about somebody who could live a normal lifespan. So we've kind of covered this a little bit, but here's re-challenge question number 1. Have you changed your mind based on what you learned? And again, the question is, cancer immunotherapies are FDA approved and used in what are the following settings? And so go ahead and feel free to put your answer in. All right, good. I've done my job. So yes, these are widely used as we talked about. So let's quickly just talk about the toxicities from checkpoint inhibitors, including the cardiovascular ones, which of course are the most relevant here. And to start off, we'll bring a case in. So this is a patient who came in with shortness of breath, and the patient has metastatic non-small cell lung cancer, fairly recently diagnosed, also has a number of reasons to potentially have respiratory problems. They have metastatic lung cancer with involvement of the lungs. They've got a pleural effusion at baseline, they've got a history of DVT, and they've also got coronary artery disease. And so they've come in to the emergency room with sort of increasing for a few days shortness of breath, dry cough, and fatigue. You can see their medications, and they have been started on immune checkpoint inhibitors approximately 3 months ago. And so, Javed, what would you be worried about for this patient?
Yeah, with shortness of breath, again, being cardiologist, I think of all the cardiac things, but I guess the other point to consider is there are a number of cardiac things that can present with shortness of breath. But among the cardiac issues, anything is fair game. I think that's an important point with respect to ischemia, myocarditis, if you're thinking cardiac. But I think the important point also is to think of issues that are non-cardiac in this patient.
Yeah, that's one reason I don't take care of lung cancer patients, because they have just so many reasons to have shortness of breath, and it's really, really tough for these patients. Well, here's some more data. So this patient had some hypoxia, as you can see on room air, was borderline tachycardic and had some crackles on exam. EKG was pretty unremarkable, unchanged from baseline, but the CT angiogram was much more remarkable. There was no PE, but you can see that, and the patient actually seemed to be responding to their cancer treatment, but there's multifocal ground glass opacities in both lungs, and the labs also, you can see, were fairly unremarkable. And there's a sample of the imaging. And so this is actually a diagnosis of immune checkpoint inhibitor-related pneumonitis, inflammation of the lungs caused by immune checkpoint inhibitors. And so the way we treat that is hold the treatment, give prednisone, relatively high doses of prednisone, and so we'll go through a little bit more. So toxicities from checkpoint inhibitors are pretty different from other types of cancer therapy side effects. So you can see with chemotherapy, you have almost all patients get some sort of side effects. They're pretty well described, so think about things like cytopenias and nausea, vomiting, and hair loss, and a few other regimen-specific side effects. And again, it only affects a few organs, but it's pretty predictable. So if somebody, patients are going to have cytopenias, 7 to 14 days after treatment and so forth. So you kind of know what you're getting, even though it's not great. Immunotherapy is pretty different. In fact, most patients actually, especially treated with single agent, have really not many toxicities. They actually do quite well day to day on treatment. But when side effects happen, they're pretty unpredictable. They can happen, in really any organ. They can happen almost at any time. They can happen 7 days into treatment, or they could happen, 7 years into treatment for the rare patient that gets that much treatment. And they can even happen a few months after stopping treatment. So it's pretty unpredictable, and it's harder to know what you get, even though day to day the experience tends to be much, much better than with something like chemotherapy. So what are these toxicities? Well, the simple way to think about it, in my simplistic way, is thinking, okay, the goal here is you're stimulating T cells against the cancer. Well, you can have some collateral damage where T cells that are specific to the organ, or if there's some sort of environmental insult happens and the T cells actually attack the organ, and you get autoimmune-like toxicity. Now, we still can't predict which patient will get what toxicity, unfortunately, but there's a few risk factors. So autoimmune disease that's pre-existing, if somebody has rheumatoid arthritis, they'll likely flare on treatment, for example. Also, the risk factors we talked about, if you remove more checkpoints, you're going to get more risk of toxicity. And so that's one of the things that we'll certainly hit on more in a little bit, is that more aggressive combinations lead to more toxicities. And as I briefly mentioned, these toxicities can affect any organ system. So certainly the heart is very serious when it happens, but we also see in our clinics that this affects the thyroid, this affects the skin, the colon, the liver. It's almost more of a question of what organs does it not affect. I think I've not seen prostate and uterus, but that's probably just because I haven't looked hard enough, to be honest. These can really affect almost any organ system. The timing is very variable too. There are a few patterns, but you look at the confidence intervals here and you look at the ranges, it's really hard to hang your hat on even some of these general patterns. Certainly rash can be very early, and things like pneumonitis tends to occur a little bit later, but it's pretty variable. And certainly when you're using combination immunotherapy, all bets are off. I've certainly seen patients get pneumonitis a few days into treatment, and so it's almost a crapshoot. There are some patterns, but certainly hard to use that to really make a diagnosis for an individual patient. And as we talked about, these long-term survival for these patients is making this really important, not only to deal with the acute and chronic toxicities, but also to think about how do these drugs actually affect the immune system? If they're reshaping the immune system to get rid of the cancer long-term, which is, of course, the very positive side of these treatments, what are they doing to the other types of immune processes? What about atherosclerosis? What about neuroinflammation? All these kind of questions are certainly something that we're all actively exploring, but certainly an important possible consideration. How do we treat this? I briefly mentioned this before, but certainly this depends on how severe the side effect is. So if you're talking about mild toxicities like a mild skin rash, well, you'll just probably deal with this symptomatically. Give the patient some over-the-counter corticosteroids, or over the topical corticosteroids. But whereas the toxicities get more severe, then you were talking about high doses of prednisone or equivalent, potentially admitting the patient to the hospital for IV steroids, and then certainly multidisciplinary care is really important. So we'll go to our second case quickly here. This is a 63-year-old woman with stage 4 melanoma. Actually, this patient was one that really got us very turned on to these types of side effects. She was recently diagnosed with metastatic melanoma and had just started immune checkpoint inhibitors 12 days earlier. And she came to the emergency room with fairly nonspecific symptoms, again, not so unlike our pneumonitis patient earlier. Shortness of breath, some pleuritic chest pain, some cough. Javed, maybe a broken record since this is not too different of a presentation, but any thoughts on this patient? Doesn't have a cardiac history, doesn't have obvious pulmonary issues either.
Yeah, so great. Again, acknowledging the fact that you have to be very broad in your differential, and the only difference between this and the other patient is that patient was a lung cancer patient, so you think of all the issues that come with the cancer itself advancing in the lung, which can cause shortness of breath. Here we're dealing with melanoma, which is probably less cardiopulmonary specific. But again, the differential here is broad. If you're thinking cardiac issues, I think looking for cardiac damage with biomarkers early on. But again, thinking broadly about the differential, like we did with the first patient, is really how I would approach this.
Well, here's the physical exam. I probably should have given you this before asking the question, but it really honestly didn't add a whole lot. So the patient was looked a little bit in distress, had a little bit of a fast respiratory rate, but was not hypoxic, didn't have a fever, and really had not a whole lot of physical exam findings. However, the laboratory data and the EKG were quite remarkable. As you can see, the troponin was quite elevated, as was the CK and the liver function tests. The echocardiogram was pretty normal, but the ECG not so much. There was the initial ECG just showed some LVH, but rapidly developed into first degree heart block, and then on the top right, third degree heart block, and then finally ventricular tachycardia over the course of about a day. So very dramatic electrocardiographic progression there. Even that someone like me can tell is really not so good. And this patient had a biopsy and was found to have immune checkpoint inhibitor-related myocarditis and also had peripheral muscle involvement. And as you can see, as you might be able to see, the patient underwent an autopsy eventually, as we'll talk about. And really, this was very specific to muscle. The smooth muscle with the black arrow really had no involvement, but the skeletal muscle and the green arrow was just completely obliterated by the immune system. And this was the patient's clinical course. They came in, they were started on steroids, but despite that, the arrhythmias and the troponin worsened, and unfortunately, within 5 days, the patient died. So cardiac immune-related adverse events, we'll talk about. Myocarditis is certainly the big one, but there certainly can be arrhythmias and other complications, as Javed will talk about. And so with that, I'll hand it over to Javed to talk about the heart. So it's good that you have somebody here that's not me to talk about that.
I bet he can do a better job than I can, or many of us, because Doug has really become a cardiologist in many ways over the last few years. I wanted to take a step back, however, before we get started talking about this specific toxicity. And this is a figure I had a few years ago for what we think of as cardio-oncology. Now, a number of experts are in the room, Cesar, Dr. Porter, many other people. But I think the issues are there are many ways in which cardiac disease and cancer intersect. So you can think of ways where there are tumors that come in the heart, And there are cases where the cancer itself can cause cardiac disease. We see this in the case of plasma cell dyscrasias that cause amyloidosis, but also patients with neuroendocrine tumors who had valvular disease and who have what we call carcinoid heart disease. So I think it's important to note that outside of therapies themselves, cancer itself can have cardiovascular issues. I think the other thing for us to appreciate is that this, at the top here, that cancer and heart disease being the number 1 and number 2 causes of death in any society, actually share a number of risk factors. So for example, some of this is very basic. So for example, if you smoke, you have a higher risk of having lung cancer, but also having cardiovascular disease. But what's been really interesting is over the last few years, we now recognize things like obesity, hyperlipidemia, diabetes, classic cardiovascular risk factors are actually important cancer risk factors as well. And this has really been very interesting. I remember a few years ago at this very meeting, not this meeting, but in the ASCO meeting, the president of ASCO got up and said obesity has replaced cigarette smoking as a number 1 preventable cause for cancer, so not cardiovascular disease he was talking about. And this has especially become apparent over the last few years with genetic predispositions. These can be inherited mutations that mom and dad give us, but also somatic mutations that we gain over time. And so the classic example of that is a condition called CHIP, or clonal hematopoiesis of indeterminate potential, where you have mutations that arise in your blood cells that are now we recognize to be important cardiovascular risk factors. And oncologists have known for many years these mutations can increase the risk of blood cancers. Obviously, all of this becomes very important for our many, many cancer survivors. So we have 18 million Americans in the, so that's obviously just in the US. That's 5% of the US population who are cancer survivors. Almost 4 million breast cancer survivors, almost 4 million prostate cancer survivors. And if you appreciate the fact that there are common risk factors that predispose you to cancer and heart disease, once you treat the cancer part, you're going to be left with a lot of cardiovascular disease. And this is, I'm going through all of this for you to appreciate, even before we start talking about treatments and the specific issues treatments have, there's a lot of areas, I think, for patients where cardiac disease and cancers intersect. But of course, this field has really exploded cardio-oncology over the last decade because of all the success our colleagues in oncology, like Doug, have had in terms of treating patients with cancer. And just to use the melanoma example, there was no treatment for melanoma a decade ago or 12 years ago. But now there are a number of treatments besides immune checkpoint inhibitors, kinase inhibitors that can use for at least a subset of melanomas. And these can have a number of cardiac and vascular effects, and I think that's really important to think about. I'm going to take this one step further and just focusing on the toxicities of specific therapies. It's a lot of stuff that we have to think about. Obviously, a lot of people think of anthracyclines and radiation at the top, but almost every breast cancer patient who goes on HER2-targeted therapy knows they have to get their heart monitored. We see VEGF inhibitors cause hypertension, heart failure, and thrombosis. And again, I'm not going to go through every one of these, but really I think the point is, as we combine immune checkpoint inhibitors and other immunotherapies with different cancer types, we're putting these on top of therapies that they have their own inherent toxicities. And this is the clinical challenge I think we're going to have to face in the coming decade with respect to what does somebody with shortness of breath who's getting VEGF inhibitor plus a checkpoint inhibitor. In fact, we had a patient this past week at Vanderbilt can present with. So it's really something for us to think about. But again, just being focused, we're going to focus on immunotherapies and specifically immune checkpoint inhibitors, which is a subset of immune-based therapies. And so Doug walked us through what these ICI, or immune checkpoint inhibitors, are. But I think it's also important to recognize that at least acutely, you can have patients present with various cardiovascular issues. The ones that we identified a few years ago include things like pericardial disease, or pericarditis, vasculitis, and just to put this in perspective, this is an autopsy on a patient that was admitted to the Brigham and Women's Hospital with nonstop arrhythmias, but on autopsy, this was all that was found. These vascular vasculitis that was throughout the body, including the heart. Arrhythmias are common, and this actually becomes important as we focus on the myocarditis, which is probably the most impressive presentation when we see these patients. And we've learned a lot about the myocarditis. This is work from us and a lot of people out there who have done really good work on this. I'll summarize some of that here. So myocarditis, as people know, is defined histologically especially, and you have to have immune infiltrates that are next to dead heart tissue. That's the so-called Dallas criteria, the triad of immune infiltrates, the dead cardiomyocytes, but also the dead cardiomyocytes being next to the immune infiltrates. And so these are mostly T cells and macrophages. With the most severe cases of myocarditis, they occur really early, and I'll show you some data for this. We have been working for many years to identify what's the common risk factor. Is it the patient who had coronary artery disease and had 5 stents placed 5 years ago? Or is it some autoimmune risk factor, like is it the 42-year-old female with lupus that gets this? But the only identifiable risk factor is actually a cancer one. So we don't see this happen in patients with necessarily patients with bad hearts to begin with. And the main risk factor is when you combine therapies, combine a CTLA-4 and a PD-1 inhibitor together. This is really important. A lot of the patients, not all, have concomitant other IRAs, and the specific ones to think about are myositis, but also a myasthenia gravis-like syndrome, and this can occur in the same patients. And as I'll show you momentarily, this can give us some insights into diagnosing this, which is always a challenge. As we've talked before, myocarditis, as everybody knows, can be a pump issue at the end of the day or an arrhythmia. And these types of myocarditis, the checkpoint inhibitor-associated myocarditis, often presents with arrhythmias. A lot of people die when they present early, although the incidence is less than 1%, which is good news until you start thinking how many additional patients are going on these therapies. And so we're going to get a number of patients getting affected with this myocarditis. And again, I summarized some of this, but again, this is classic myocarditis with T cells and macrophages, a lot of EKG abnormalities, a lot of early presentation of the myocarditis. So we looked at this through a large Vigi-based database, and the average median time of presentation with myocarditis from the first time the patient gets exposed to therapy is 25 days. Which means, being that these are biologics, they get it every 3 weeks, most patients have received 1 or 2 doses only. And I think the other issue is this concomitant myositis, where checking a CK in this particular case becomes really important. And I think that's really important to think about. And again, this is a bigger problem, of course, although we're going to focus on myocarditis. We've been able to actually put together a registry of now over 750 cases from around the world. And this is literally from around the world with people who have contributed cases. And so as a result, some of the data I just told you about really comes from a really nice international collaboration. And if anyone's interested, this is a registry we started at Vanderbilt. There was really quite a few people who have contributed and who are leading the way in terms of the next steps of what's the best way to diagnose, what's the best way to treat with these checkpoint inhibitors. And 750 is actually, turns out to be a pretty good number of patients for which we can reach some conclusions. I wanted to put this just for you to sort of understand the gravity of this. This is actually a mouse heart. We have generated mouse models of myocarditis. So this is cross-section of the mouse. This is a left ventricle, right ventricle. And the blue and the green here really points to a specific type of T cells that shouldn't be in the heart. And you can appreciate here the infiltration that occurs at a very high magnitude, albeit in a preclinical model for these patients. And so I think the next step, and we can make this as kind of as sort of general and we may go back and forth on this, is some of really the challenges that we face in terms of diagnosing these patients and diagnosing them promptly, grading them, and managing the patients. And so now we were going to go to the next question, which is, which of the following would you assess or consider as part of establishing a definitive diagnosis of checkpoint inhibitor-associated myocarditis in a patient with cancer refusing immunotherapies who are receiving cardiovascular symptoms? Again, we went over how these cardiovascular symptoms can be very nondescript and could be shortness of breath, which could be about anything. So you may use an EKG, imaging, biomarkers, myocardial biopsy, skeletal biopsy, 1 through 4, 1 through 5, or I'm not sure. So go ahead. And so with that, we'll move on to a case that we actually, both of us encountered at Vanderbilt. And this was a very interesting case. So I was, this patient actually presented on a Sunday to an outside hospital. It was a 75-year-old male with some EKG changes, shortness of breath, and a troponin that was 10. And so being cardiologists and good cardiologists, they of course thought immediately this patient had a myocardial infarction, transferred them to the Vanderbilt cath lab, at which point the patient underwent an angiogram. There was a occlusion that was seen in the LAD. Again, the patient's 75, not clear if that was the contributing factor, but it was 70% nonetheless. And so our interventional cardiologist put in a stent and sent them to the CCU because the patient looked a little bit sick. The problem was Sunday night rolls around now, and the patient continues to be sicker. The troponin, which was we figured would go down, or the team figured would go down to after getting the stent placed, continued to increase. The patient actually went on to go into complete heart block and then had to be intubated. And so this is the EKG, that's sort of where the patient's initial EKG, but as you can see, the patient deteriorated enough such that they needed a pacemaker placed. And so at this point, something very interesting happened. Deb Dixon, who's one of our fellows now, who was a resident at the time, actually talked to the patient, not to the patient, but to the family, because the patient at this point had been intubated. And it turned out this patient, who had been treated at the outside, had kidney cancer, had received sunitinib before, but was now just started on a VEGF inhibitor, a drug like sunitinib, as well as an immune checkpoint inhibitor. In fact, had received 2 doses, and the first dose was received a month ago. And the second dose was received 5 days before admission. And so, Doug, again, I'm going to put you on the spot a little bit, since you are now a cardiologist. I just said you're as good as any cardiologist. What would you do next here?
Well, as an immunotherapy doctor, if you're a hammer, everything's a nail. So I would be very worried that this is checkpoint inhibitor associated, and I'd be very apt to give this patient high-dose steroids, although I would call you first.
Yes, so I think this is really important. The patient's sick. You may not get a prompt diagnosis early on, which, as we'll talk about, may involve imaging, which was going to be tough in this patient given how sick they were. But I think one of the areas for us to think about is how we have to think about getting biopsies early. And that's Dr. Iliescu walking out of the room. He's the interventionalist at MD Anderson. They're probably asking him to get a biopsy on a patient as we speak. So I think this is really important in terms of what we think of as definitive myocarditis, probable myocarditis, or possible myocarditis. And I think this is really important to think about this. Not every patient can get a gold standard biopsy. Not every patient can get a diagnostic CMR. And I think thinking about how much we think about the myocarditis and how we diagnose it, especially with what's in our arsenal in terms of what we can provide at various places for the patient, I think becomes important. In my personal opinion, this is the one case where we have to be more aggressive and tissue is the issue. So I think for this type of syndrome, because the diagnosis and correctly diagnosing these patients is so important, both in terms of what we do for the patient, but also potentially withholding life-saving immunotherapy, I think we have to be right on the diagnosis. And I really myself think, and maybe we can expand this for questions later, that tissue is the issue. And I think for this type of myocarditis, just like giant cell myocarditis, being able to cath the patient, ruling out coronary artery disease, acute coronary syndrome, but also getting tissue would be very important. And I think the tissue, and this is exactly what happened with this patient. This is the biopsy, of course. The patient had received 1 dose of high-growth solumedrol, but we don't expect that to really ameliorate in terms of the inflammation. And we have some nice preclinical to support this, and the patient had classic myocarditis. I think the other take-home point is checking a CK on these patients, and if you can't do a myocardial biopsy, I think there's some utility of doing skeletal muscle biopsy, which is obviously much easier, and that can be done just because you want to be right with the diagnosis and not sort of be treating something that you think is myocarditis, but you don't have actual proof. So going back to this question again is now kind of thinking about definitively diagnosing myocarditis. Which one would you answer now? Go ahead. Let's see what the answers show. I guess I should click forward here. Good. We're doing our job. So 7 is 1 through 5, which again, I think if you can't do the myocardial biopsy, first of all, initially when you're doing biomarkers, that it goes beyond just cardiac biomarkers. Troponin is what we generally use, although there are other biomarkers that at some point should come, and we can always think about better biomarkers. But CK is also important because of this concomitant myositis. And if you can't do the myocardial biopsy, skeletal muscle biopsy would be something I would consider in all these patients in terms of a very definitive diagnosis. And so I think there's been some nice work by various people, including Dr. Tom Nealon at Mass General, showing that high-dose steroids can be effective. This was a retrospective study, and although many of the guidelines in oncology say 1 mg per kg, really giving a high dose initially is what we have basically and what should be considered in these patients. And I think that's really important for us to think about, even before you can do the biopsy, as was in this case. However, in this particular case, the patient continued to deteriorate. And so what can we do next? And so we only gave 3 days at this point, so one answer could be that you really want to give 5 days before considering other therapy. And then number 2 could be considering other immunosuppressive agents, including a drug called abatacept, but other things that we use generally for heart transplant rejection in these patients, or you're not sure. So go ahead. And now I'm trying to go forward. So a couple of very quick slides. We have been thinking a lot about this in terms of how to model this in mice. And for those of you that don't pick up mice every day, and I happen to have a basic science lab, you can actually model checkpoint inhibitor-associated myocarditis in mice. You can give the drugs to the mice. You can even put tumors in the mice and then give the drug so you can see what effects various treatments have on the tumors. But in this particular case, in the bottom here, we've made genetic knockout mice where we've taken out the very targets of immune checkpoints. And these mice miraculously get myocarditis that pretty much mimics what we see in patients. And this is some great work where one of our other colleagues, Dr. Joe Ali Salim, it was a case report in New England Journal of Medicine where abatacept was effective for a patient that was basically failing. And I'll be the first to admit this is one case, although as I'll talk about momentarily, he at least has a talk coming up, which I think put this more in perspective. If we're going to use abatacept, what dose we should use and so forth, so be tuned in that. I'm going to now move on to another case. This is a male 67-year-old. We're back with our friend lung cancer again, so again, complicating things more in terms of what the shortness of breath, which is what this patient presents with. So this patient had combination checkpoint inhibitors, got chemotherapy on top of that, came in with shortness of breath, and said his heart's racing. Troponin was 10, EKG looked like this, and I think the next step in this case, the patient got a biopsy. Interestingly, the EKG looked pretty okay. Not much on the echo, and this is sort of a very recurrent theme. The EF can be completely normal, even in patients who are doing very poorly. Again, I think one thing to take home is this, again, could be myocarditis, but it also could be acute coronary syndrome with a troponin that's high, nondescript EKG, again. And so I think ruling out coronary artery disease would be important. But I think making sure your interventional colleague, or if you're actually doing the case yourself, stopping then and saying, well, there's no coronary artery disease, what else could this be? And while you're there, I know that probably requires another stick, at least if you're in the US, you can get a biopsy, and this patient again had classic myocarditis. So in this patient, got methylprednisolone, 1 gram, high dose, and the troponin kind of stayed around 10, went up to 13, but then was coming down to 7, and we were saying, well, the patient may recover and actually do okay. In fact, the patient was doing fairly well, and this is actually one of the first cases I had at UCSF when I moved there, except the overnight resident in this case got a new call saying the patient had developed a new heart block. And so the question that really comes about is, what do our oncology colleagues say in terms of what to do for these patients? And Doug, this is the NCCN, which is the National Cancer Center Network. Do you want to take us through it? This is what I learned the oncology guidelines say for all sorts of things, including side effects of therapies.
Sure, yeah, we've learned some lessons for some toxicities that don't respond to steroids. For example, if colitis doesn't respond, things like infliximab can be very helpful, which makes a lot of sense. Infliximab works for Crohn's disease and other types of GI inflammation. And so we've tried to learn, take those lessons that we've learned there, and with our cardiology colleagues, try to figure out, what do we do for the cases of myocarditis that don't respond. And unfortunately, we're still working on it, I think. So there's a number of different potential options. There's successful case reports with a number of these different treatments, ranging from abatacept to mycophenolate. I would say at this point it's controversial, wouldn't you say, as far as what to do, when to start these other agents? Do you wait till the patient fails? Do you just know up front that these are bad cases and start initially? But there are some guidelines out there that can hopefully guide and help us as we try to manage these patients.
Yeah, I think one of the key things is we're really in a data-free zone. I think the other thing we think of as cardiologists is what mechanical support, in the cases where there's EF drop, can come into play as well. But I'll be the first to admit what we do next after the steroids is still sort of an area I think a lot of us are trying to learn from. So in this case, the patient got abatacept. This is based on some interesting data that my colleague Dr. Salim in Paris actually shared with me. and the patient got 20 milligrams per kg, which is actually above the dose that we generally think of with abatacept. And in this case, the troponin kept going down, and the patient's arrhythmias actually ended. So again, this is one case. We can't make general comments on one case. But I guess the other point is going back to this question of what to do next. I think the key is thinking about other agents. And I'm the first to admit we don't have the data where you just about what to use specifically, but thinking about more than steroids in these patients, I think, would be very important. So doing this question again, if we can do this one more time, what would you kind of answer? So. Oh, these are the questions. Good. So we have a lot of questions to go through, it looks like, and we're going to go through them. So this is great. I think people are sort of considering. I wish I could tell you the exact drug and dose that one could use, but that is still something we're working on. I do want to call your attention, however, to this session happening at 3 o'clock today. Literally great speakers, Dr. Chunru Lin, who's at MD Anderson, Craig Beavers, who's part of the AHA Cardio-Oncology Committee that I served on previously, Dr. Salem Hayek, Dr. Alan Beck at UCSF, but Dr. Salem specifically, building on that initial New England Journal of Medicine case, is really going to present some outstanding data in terms of how to best treat these patients. So if you're around today later, I think this session and specifically his talk can give you some more perspectives about what to do and what to use for these patients. So I'll go back there in case people want to kind of copy this. I know a couple of people were trying to take pictures, but I think you're going to learn a lot, and I think there's going to be some good discussion here. This is really important, and I think this is something we can talk about. We've debated about this for time. This is a serious problem. Admittedly, it occurs in a very small subset of patients, and I would consider 1% a small subset. Should we do something more in terms of screening patients at baseline and in terms of what we do for follow-up for these patients? So screening and surveillance. I personally think every patient who's going to get an immune checkpoint inhibitor should get a baseline EKG and biomarker troponin. And I'll show you some data why that's particularly important. So that's the screening part. This is before you give the drug. But I think in terms of what we do with surveillance, it's something we have debated for some time as to whether we should do continuous EKGs or troponins as a surveillance mechanism on every single patient, recognizing that 99% do quite well and there's no issues. And so at least at this point, and for all of these sort of thoughts, we always have oncologists who kind of make sure we don't go too far the other way. For high-risk patients, I think a lot of people agree we should have biomarkers that should be done every 2 weeks during the first 6 weeks of therapy. Now, how you define high risk becomes really controversial. I guess I showed you the data where combination therapy is clearly a risk factor. But what about a patient who is EF is 30% or 35%? Should we be screening or doing surveillance tests on those patients? I would love to kind of think about this and debate this. For this particular manuscript, and this was led by Dr. Lorenz Lehmann, who's at Heidelberg, Germany, we didn't think EKG serially would be very helpful, and that's because I think we're going to get pushback from oncologists who are effectively seeing these patients, stopping their clinic, and doing EKGs on the patients. But of course, everything else, if the patient has symptoms or has any abnormalities, being a good doctor and thinking about all the different things is certainly fair game. But this is something I think we're going to go back to, Doug, and talk about and see whether your thoughts have evolved, especially over the years. And the reason, but even with this, I want you to think about this and be careful, because what I mentioned to you was in many cancers, we're now combining therapies. In kidney cancer, and this is a nice paper that was led by our colleague Brian Rini, who's a kidney cancer doctor, These are patients who had never been treated before, frontline treatment, new diagnosis of metastatic kidney cancer, who were randomized to 2 arms, patients who receive VEGF inhibitors, which up until now has been standard of care, and in another arm, they would receive a VEGF inhibitor, albeit a different one, and a checkpoint inhibitor. And I think one of the the things that was very interesting, as every patient in this trial had an echo and a troponin, is the first part, which is up here, which is how many patients have a significant drop in EF when you compare it to the baseline. And we can define these various ways, whether it's greater than a 10% drop or reaching a minimum, a maximum that we determine for the echo. So lower, I guess lower end of normal for these patients. And a significant number have a drop in their ejection fraction. Now, is that the checkpoint inhibitor, and are they having mild cases of myocarditis, or is it the VEGF inhibitor? And it becomes really tough to decipher this. And so this is the world we're going to have to live in. The other side of this that was really interesting, again, these are frontline patients, never got any treatment before, is for this particular study, everybody received a biomarker. And this, to our surprise, 19% of the patients had a troponin T that was positive at baseline. 1 to 2% of the patients had a troponin I that was positive at baseline. And up to 20% of the patients either had a positive BNP or anti-BNP in the case. And again, this kind of calls attention to the complexity that we live in with respect to patients who've never gotten treatment. This was baseline, who already have abnormal biomarkers at baseline. So I think checking the baseline and making sure the subsequent check that you see is not an actual increase, I think becomes really important. This is the last case. We're going to go through this quickly because I think the real thing is really getting interactions from you. There are many questions that have come through the online and so forth. Is another quick case. This is a 70-year-old prostate cancer patient who received a novel checkpoint inhibitor. And this is what the MRI shows. And in this case, the patient had myopericarditis, with most of the symptoms of the chest pain being explained by this myopericarditis. As you can see here, slight troponin increase, but I think everybody on the MRI can recognize the pericardial issue that comes about. Again, we treated this patient with high-dose steroids, but I think one of the things I learned from my colleague Alan Klein, who's probably the world expert in pericarditis at the Cleveland Clinic, who's been seeing these patients for many years, is at least he starts with NSAIDs, colchicine, and then moves to steroids. And I think the issue with this patient was when you try to titrate off steroids for pericarditis. And I think there's been some nice studies, including a New England Journal of Medicine paper by Allen, where other agents such as IL-1 beta inhibitors can be helpful for patients with general pericarditis. And again, I think the challenge is applying these to our patients. And I think this is our last couple of slides. Really, a multidisciplinary team is critical. And I talked about Doug Johnson, who's here. And when I was at Vanderbilt, we were fortunate to have Victoria Finnemore, who's sitting in the back, who was our nurse. And I think she was many times the glue that makes sure everybody was sort of talking about these patients. And it really, I think, having a multidisciplinary team to approach these patients, given that the IRAEs are not just in the heart, but other places like myasthenia gravis-like syndrome, getting a neurologist or a rheumatologist could be kind of important, I think, in this. So I think at this point, we're going to go over to the question and answers, and we can do this either way. Should I just start reading these? Now, I'm going to have the chance to put Dr. Doug Johnson on the spot for a couple of these. And I think one of the things that comes up, we talked a lot about immune checkpoint inhibitors specifically, but what about CAR-Ts, and what do we do for those? I know as a melanoma doctor, you don't use them necessarily as much, but as I've learned, Doug wears many hats. One of this is sort of leading this immunotherapy program. And so what do we do for CAR T patients? What kind of toxicities we see? So if you could kind of expand on that.
Yeah, I think we're still learning, but I think in general, CAR T, these are actually engineered cells that are directly given to the patients, mostly to target hematologic malignancies. And these basically, the main cardiac side effects of these are more related, to my knowledge, more with cytokines. So you're basically, giving patients, the ones that have cytokine release syndrome, it's almost a sepsis-like syndrome. So you're talking about arrhythmias and so forth, tachycardia at minimum, and of course, strain on the heart from that. To my knowledge, there's not a whole lot of direct myocarditis or other cardiac toxicities other than just sort of the extra strain on the heart. And so for that reason, you want to certainly be careful when thinking about baseline cardiovascular status for some of the patients that are going to get some of these treatments, because you certainly don't want to, put somebody who's already got bad cardiovascular disease into and give them an MI when you give them treatment.
Good. And I think this is also kind of a moving field, because the classic CAR Ts that have been approved are very tissue and specifically B-cell specific. They generally target CD19, which is only expressed in B cells. So the issues we see are kind of this vascular leak syndrome. And some nice studies have shown there are actually patients can get mild cardiomyopathy or troponin increase or AFib. Although one of the questions, one of the issues I push back on is, what's the significance? A lot of patients who are really sick who get the cytokine release syndrome can have atrial fibrillation. Is that a cardiac specific thing versus a more general patient being really sick and having this autoimmune phenomena that's sort of occurring? I think the other issue is, as we moved on with other CAR Ts that are now targeting other targets besides CD19, we may actually see cardiac specific effects. So it's something I think we should really think about. And so the other question I have here is, what should we do in terms of EKG that's obtained? How often should the EKG be checked in oncology patients who are receiving immunotherapy? And this is a question that we really grappled with a lot. I think everybody deserves a baseline EKG and baseline biomarker. The problem is, if you're a busy oncologist having to stop your clinic, and again, we're not involved as cardiologists in the care of these patients at this point. This is about surveillance now. Having to do the EKG in a busy oncology practice, and then more, as I've learned, more worrying for many oncologists, having to interpret the EKG can be very troubling. And so this is an issue that we went back and forth on, and I at least think for us in cardiology to think about EKG when we're seeing the patients is absolutely important. But as oncologists, expecting them to do an EKG, no one's, in my opinion, is going to do it. And I'd love to hear Doug's thoughts on this. I think biomarkers is another thing, and that's why, at least for that set of what I would only call consensus statements, we thought doing the biomarkers would be much easier because you add it on to other labs that we check.
Yeah, I mean, my sense of the data is certainly that troponins are pretty darn specific for myocarditis, and so getting the EKGs where you're going to have so many nonspecific findings and so forth, this seems like a nightmare to me as an oncologist. But obviously, if we felt like it really moved the needle, we would do it. But I think, to me, I'm not convinced that it will.
So I was kind of expecting coming to a cardio-oncology to see this. Next question, which is, what's the role of strain in these patients? Now, as some of you know, I'm not a huge fan of strain in general. I think, and there's an editorial myself and Ron Witteles, who's at Stanford, wrote for a very nice study that was done for other indications. These are anthracycline patients in JACC last year. But here, there's actually some nice data, although I'm going to kind of put this in a different context from, again, Dr. Neelan, showing that strain can be sensitive for detecting myocarditis. My issue with strain, however, is many times in these patients, we don't have a sensitivity problem, we have a specificity problem, where the troponin increase or the strain abnormality could be, again, just about any cardiac issue or even non-cardiac issue. So I think for us, the really sort of the challenge will be having specific platforms to think about. And so we're doing this in a couple of contexts. Some of you may have seen a very nice New England Journal of Medicine paper by Dr. Pilar Martin, who's in Spain, looking at garden variety myocarditis and how a certain microRNA could be very specific for detecting myocarditis, in fact, distinguishing myocarditis from other forms of ischemia or myocarditis from ischemia in patients. And whether that applies to checkpoint inhibitor-associated myocarditis would be sort of important. And then we think about other forms of imaging, and just for thought, I like to think about PET imaging. Of course, we use FDG PET, which is a pain to do, not necessarily specific, but what about if we use a new tracer? There are many immune-based tracers that are coming through the pipeline, and I think in the future we may be looking at other ways where we actually address the specificity problem. So that's at least what I think in terms of that question. And so here's a tough one, Doug. What about patients who have COVID around the same time? I know you wrote a very nice paper on this issue, because you get the immune checkpoint inhibitors, you get COVID, which has a lot of autoimmune phenomena, and what do you do for those patients? Do you stop treatment, or?
Yeah, it's certainly a complicated question. We and a lot of other groups have looked. Do patients who get COVID while they're actively on checkpoint inhibitors, do they have worse outcomes? And it seems like the answer is generally no. There's maybe some data that lung cancer patients may do worse, but it's always hard to know, are they doing worse for other reasons as well? So it certainly seems like those patients do okay. And so we initially were quite concerned to use checkpoint inhibitors in the context of the pandemic, but we've certainly become much more comfortable with that given the availability of the data. Certainly that doesn't answer your question about if somebody comes in with a concern for myocarditis. Is it COVID myocarditis? Is it vaccine myocarditis? Is it immunotherapy myocarditis? Certainly that doesn't necessarily answer the question, but it does seem like these agents are safe to use in this era. The other quick thing I wanted to point out that I don't think we did is sometimes these patients have respiratory distress out of proportion to what you would think on their cardiac exam, and so in those patients, think about diaphragm. That's the one issue that we've had several patients that seem to be getting better, their troponins going down, but you can't extubate them. Why can't you extubate them? Their lungs seem fine. So think about the diaphragm in those cases as well.
And I think both with that and as well as another issue, which is the dose of abatacept, which is another question here. I think everybody, if people are interested, there's going to be some nice data from Dr. Salem later today that sort of calls attention to this, both this issue of skeletal muscle abnormality, which can be diaphragmitis, frankly, and these patients get hypercapnic. They're probably some of the high-risk patients as well as thinking about the dose of abatacept. There's at least one trial looking at a regular dose of 10 mg per kg. I'm not sure that's the right dose to use these patients, because as anybody who's looked at how abatacept was indeed developed early on, you really have to look at the receptor occupancy, which is this molecule called CD8086 for these patients. Are we going to have time for one more question, or how should we, because we have a ton of questions here. I'm going to put another one, Doug, and you're really just doing so well with these questions, we thought we would give you some more. What about re-challenging patients? You have a patient with myocarditis, you take care of them, you give them steroids, the troponin goes down, and they still have the metastatic melanoma. What do you do then?
Well, I think the first question is, do they need re-challenge? There's some patients who actually will get toxicity, you stop treatment, they continue to respond 5 years later. So not every patient needs re-challenge. Also, there may be a patient who, clearly progresses through therapy and they're not benefiting from therapy. So I think first getting the question of, do they really need re-challenge? But the second question is, can you do it safely? And I would say in general, the data suggests that roughly 40 to 50% of patients who have a toxicity that are re-challenged flare again. And so some of it comes down to the frank discussion with the patient and how much they need it and how life-threatening their presentation was. Obviously, if somebody has a troponin of, 0.2 and you're really not totally convinced, or it has mild evidence of doing it, you probably would be more apt to do it than somebody who ends up in the ICU with fulminant myocarditis. So I think all those factors can play into the decision.
And then somebody who does have myocarditis and you sort of treat them, and let's say you decide, actually, I'm going to take one step back. One thing I do in my practice, first of all, you have to look at the cancer, as Doug said. Is it some frontline treatment, or is it some adjuvant treatment, or is it the patient have metastatic disease? And if they absolutely require it, since we see a lot of combination therapies, if you're going to re-challenge, I would certainly start one therapy in terms of two therapies. So that's just at least one admittedly made-up thing that I follow when I look at these patients. But the other question that comes up is, how do we monitor these patients? Obviously, they're going to be engaged with a cardiologist who have myocarditis, and let's say they do okay over time. And I think the decision about whether you re-challenge them with immune checkpoint inhibitors, again, really is a group decision, an oncology decision. But how do we monitor these patients over time? How often do we do echocardiograms? And I mentioned 50% of the patients may have a low normal EF, even though they may have fulminant myocarditis. And at least in our group, we've been doing this every 3 months initially, kind of following them. Again, this is a patient that has done well. And now I think the big thing is they're now engaged with a cardiologist, hopefully, where it's less of a burden for us to do EKG and echocardiogram compared to an oncologist who has to, again, just think about how busy their practice is, and they have to order an echo and interpret an echo, order an EKG and interpret the EKG itself. And again, I think maybe I can turn this back to you one more time. I know a number of institutions have put together nice multidisciplinary programs, and I think a lot of people here could be thinking, well, I'm a cardiologist at the end. How do we combine sources with the oncologist? And I know you have a nice program at Vanderbilt called V-Point, which is a multidisciplinary sort of program. So in terms of program building, any tips or anything in terms of how people here could proceed, talk to the oncology colleagues, and put together multidisciplinary programs?
Well, I think certainly it's important to have the go-to person from the clinical standpoint to help deal with these things. I think these are pretty new clinical syndromes, and so I think a lot of people are excited about learning more about them, characterizing them, treating them better, and so I think just there's a lot of excitement about treating these things. So just finding other excited people is I think the key.
I have a lot of other questions, but maybe if somebody has specific questions, I will repeat the questions so our colleagues who are joining us virtually know. But any thoughts or any and it's totally okay if you say, you know what, I think you got to do an EKG on these patients and follow up and so forth. So any thoughts? I know we have some people who are leaders in this area. I know Charlie Porter is there. Dr. Iliescu, go ahead.
So excellent presentation, and actually I have to second you, Javed. Doc did a phenomenal job. You sound like a cardiologist, Doc, so you really know it. I have a question. Have we ever looked of how many patients we have with sudden cardiac death on immunotherapy? Because that's the biggest question. If the patient gets to his clinic and is still symptomatic, we can do an EKG when he's really sick. But if the patient, I know we looked at a lot of things, and we looked at sudden cardiac death. And actually, we didn't look at it so far. So if you have any data about the...
Yeah. So there was actually this case with my colleague, Dr. Mark Banaka, who now runs this CRC effectively in Colorado. He was the safety person at the TIMI, one of my old colleagues from the Brigham. We actually went through this kidney cancer trial. And again, we can call it sudden cardiac death, but you have so little data, you really have to call it sudden death at the end of the day, because we don't really know what the death is. And we actually saw a substantial number, somewhere in the order of 6 to 7 patients out of 500, which is a good number of sudden deaths. And we really don't know how to either classify these patients, whether that's due to cancer, whether that's due to PE or something totally different. And in the case of this particular trial, which is metastatic, these are sick patients at the end of the day. And so I think it's an area we need to think about getting more data. And again, I would call it sudden death. You obviously think about cardiac issues, but also important to think about non-cardiac issues as well. But that's, I think, one area we need to really think about and get more data from. Any thoughts?
Yeah, not much to add. I think the rate of sudden death has gone down a little bit since we've learned about this syndrome, and so people are actually checking the troponins and so forth, and it's not someone going home and then expiring after they could have been salvaged.
Charlie.
Javid, Doug, it's really great to come to these sessions because I think I'm kind of up on this, and then I realize I'm not. And when I go, the tip of the iceberg is like my ignorance is all below surface here. So it's really great to come in and get a refresher and guidance. Javid and I published a patient we took care of that had 2 checkpoint inhibitor tumors, renal cell and metastatic melanoma. We used Nevo, and tumor responded, heart block, EF 20%, while the patient had been minimally immunosuppressed because of his progressive disease.
And this is a heart transplant patient. 'Cause
Heart transplant,
you
19
mentioned
years
that
out.
earlier. So this is a heart transplant patient that's been 20 years out.
So I told the patient, you know, we can buff up your immunosuppression for your heart like you just got transplanted because you were on 19 years out, never rejection. We did that, and he got 11 more treatments with Nevo after he'd nearly died following 6. He ended up dying of vasculopathy. His whole apical LAD went out, and I think vasculopathy or accelerated atherosclerosis, and Javid, you've talked about this, is different than vasculitis. It's an acceleration of a non-lipid-driven vasculopathy, and I think that's another issue when you're seeing these patients to think about, and is this vasculopathy. And finally, we started I'm at the University of Kansas Med Center, KC. I started a e-consult service, just cardio-oncology at kumc.edu, and sent that out to every oncologist in the system. I haven't gone statewide with it because I don't have the bandwidth. If anybody needs a job in cardio-oncology, call me. But so the oncologists, whenever they get these EKGs, and the better the EKG computer system, the less likely it is anything's going to be normal. And I think if you're going to do screening, you have to have kind of a system to let these people respond, because their hair gets on fire. The oncology nurses, they see some abnormality on the EKG, everything's checkpoint inhibitor myocarditis, and you've got to have an outlet, an off-ramp for these people to get help on these EKGs, because the computer will drive them crazy. And we respond within minutes, you know, on these things. Somebody in our system always picks these up during the day. Thankfully, they don't do them at night in the clinics. But it's a challenging area. And one other thing, if I could just ask, I don't seem to see many referrals from the breast cancer population on their checkpoint inhibitors. Do you see that? I mean, I just don't know. Is there something different about that drug? It's usually not IPI. It just seems to be they're getting away. It's like breast cancer. It's just different. It seems different. Is that true, or am I just missing it?
Yeah, it's a great point. I don't think it's been studied in detail, the exact incidence rates. But for one, only really triple negative breast cancer is using this, so you're not doing it for the hormone positive or the HER2 positive. Now there is increasing indication that used to be just PD-L1 positive refractory patients. Now there's some in the neoadjuvant setting, so we'll see if that ups the ante. It does seem like some toxicities are decreased with the use of chemo plus checkpoint inhibitor. Again, there's not great data on this because it's always hard to compare apples and oranges, but it does seem like these patients maybe get a little less colitis and so forth, and so I wonder if they might get a little less myocarditis. That's probably something we should, study and look at. It's a great question.
And I think the transplant issue is really a big challenge. I remember talking, actually in Chicago at Northwestern, it was a medicine grand rounds, where one of my friends who was when I was an intern, he was my resident, who was a nephrologist, said it's easy. We just put them back on dialysis if they had a kidney transplant. We obviously don't have that luxury with heart, and so it really becomes a challenge. And I would also almost spin this back, the case that you just mentioned, and this is a nice paper that by Charlie that was just published. What do you even call that? The patient had been 20 years out of transplant, never had rejection. After getting the drug, they of course had sudden, they got sick, their troponin went up, you do the biopsy. Do you call that myocarditis, or do you call it rejection, or does it matter really? So I think that's the other sort of thought.
I think the editors at Journal of Heart Lung Transplant helped us with that. At the end, this case report, I mean, it took longer. I mean, it took 2 years to get this through. We got 19 different resubmissions, but they finally said, change, we were saying myocarditis, rejection, they said, change this to severe graft injury. And that, so throughout the paper, that was the last hurdle we did, was we took out both rejection and just said, it's injured myocardium. Who knows why? Can't tell what the T cells were thinking. Yeah.
And I think I'm going to actually kind of have a last sort of thing that I'm going to put, since we have Dr. Johnson here. What do you see coming through the pipeline? I mean, you mentioned this thing called LAG3. I mean, what is that? And besides LAG3, what else should we be thinking about? Because as we all know, this field is really moving. And can you give us some sense of what's the magnitude of therapies that are coming, and which one do you think is going to work, and which one may or may not have cardiac issues? So
There've been a little bit of a lull, although it's not very long. There've been a number of negative checkpoint inhibitor trials as well, and so there was some question. But with the onset of LAG3, and there's a number of other agents that are being developed, I think we're probably headed towards triplets and quadruplets. So it's coming more and more. So be ready.
And do you envision LAG3 by quadruplets or triplets? It's LAG3, PD-1, and CTLA-4?
Right. Low-dose CTLA-4, LAG3, PD-1, maybe TIGIT or other checkpoint inhibitors. Again, we learned lessons from tuberculosis and HIV and hematologic malignancies. You need multi-drug combinations to get rid of these tumors.
Good. Well, we can sort of have additional thoughts. Any other burning questions? I think there was one question potentially going up here, if you would, and we'll make that the last question just to...
Yeah. Sorry. I was wondering, I know the hematological cancers are the most common in this country and probably around the world. Is there any cardiovascular implications of treating those diseases that were not necessarily talked about today? I know those are, like, as Doug mentioned, very commonly treated with CAR T and also different combinational drugs. I know R-CHOP's pretty common there. But, yeah, I was just wondering about the the ICI effects with the hematological cancers.
Yeah, there's only a handful of these that respond, so things like Hodgkin's lymphoma, primary mediastinal B-cell lymphoma, but the more common types don't really respond to checkpoint inhibitors so well, CLL, diffuse large B-cell lymphoma, and things like that. So it is, maybe an issue in combination going forward, but we don't really use them a whole lot at this point. But you're right that, certainly, we now, the ABVD is now being used in combination with nivolumab for Hodgkin's lymphoma. And so, thinking about those kinds of combination side effects are, maybe important too.
I know the Hodgkin's Day paper run by my old colleague, Dr. Seufer at Dana-Farber, I think that ended up having 2 deaths from myocarditis from a very successful study, which is only 30-some patients. I think the other part of this question, again, though, is there's so many other therapies that we have to think about. So just to run a few, you mentioned R-CHOP. Of course, that's anthracyclines. We have to worry about it. But what about CML patients who get on 2nd, 3rd generation agents that have vascular disease that we have to think about? What about a CLL or mantle cell lymphoma patients who gets a drug called ibrutinib that causes atrial fibrillation? Again, an unexpected cardiac issue that we're encountering in our clinics. And as you think about that iceberg and that other picture I showed, certainly we've talked about immune checkpoint inhibitors here, but the kind of the bandwidth of interactions between cardiology, oncology, and the different therapies that have very different cardiac effects, cardiovascular effects, I should say, become really important. So there's a lot of laundry lists that we can go through with hematological malignancies, where it's not necessarily just checkpoint inhibitors, but other therapies that have various, a myriad of cardiovascular issues. So again, I think we don't want to get kicked out of the room, and we want people to be able to attend the AHA sessions. I mentioned at least there are a couple of nice cardio-oncology sessions that will be happening. We're going to have a debate session in the morning, and I mentioned the immunotherapy for those of you that are interested in this later this afternoon. So thank you.
Thanks.